Good day, dear colleagues and fellow blood banking advocates. So happy Blood Donor Month. So this morning, we are going to open our clinical forum with a topic that sits at the very heart of modern hospital practice. Transfuse smarter, evidence-based thresholds across specialties. So as clinicians, we often face the reflex temptation to fix the numbers on a laboratory printout. However, remember that blood is a scarce living resource, and every transfusion carries an immunologic footprint. So over the next 15 to 20 minutes, we will look at the latest landmark trial data across intensive care, cardiology, neurology, surgery, and obstetrics, and what does these data really say about where safety ends and unnecessary exposure begins. Our roadmap for this session focuses on three clear objectives. First, we will differentiate red blood cell thresholds, specifically contrasting the standard restrictive thresholds against clinical situations where a more liberal target is highly justified. Second, we will update our procedural platelet targets by translating the newly released 2025 international guidelines straight to the bedside. And finally, our ultimate goal is to optimize blood stewardship using hard clinical trial data to safely minimize unnecessary product exposure for our patients. What do we mean when we talk about optimal transfusion practice? So according to the latest clinical consensus literature published this year by Carson and Kleinman, it is a delicate balancing act, which means providing a sufficient volume of blood products to maximize a patient's clinical outcome and tissue oxygenation while aggressively avoiding the toxicity, volume overload, and resource drain of unnecessary transfusions. So in medicine, more is not always better. Every unit we withhold when it isn't strictly indicated is a win for both patient safety and our hospital blood supply inventory. To achieve this balance, we must explicitly state the fundamental rule. The decision to transfuse is multifaceted. It cannot and should not solely depend on hemoglobin level or the binary presence or absence of symptoms. So when evaluating a patient for blood administration, we must look at the complete picture. Their immediate hemodynamic stability, their underlying chronic comorbidities such as active coronary disease or acute brain injuries, and where applicable, patient preferences. So a hemoglobin of 7.2 can look incredibly different in a walking oncology patient compared to an unstable patient in an active ischemic window. So for the vast majority of our hemodynamically stable patients, the clinical data overwhelmingly favors a restrictive transfusion strategy. So this approach is defined by three main pillars. So triggering transfusion at lower hemoglobin targets, typically 7 to 8 grams per deciliter, giving less blood by ordering exactly 1 unit at a time, and reevaluating the patient rather than aiming for historically high normal target hemoglobin levels. So this isn't just in an institutional preference. So it is actually backed by the highest tier of medical evidence, including the landmark Cochrane database systematic reviews led by Dr. Jeffrey Carson. Now let's look at the hard numbers from that massive meta-analysis, pulling 1,000 of patients. So when you compare a restrictive strategy to a liberal strategy, the restrictive approach predictably slashes the probability of any patient receiving any blood transfusion by 41%. And here is the critical safety data. There is absolutely no significant difference in 30-day mortality, in infection rates, in risk of myocardial infarction, stroke, heart failure, rebleeding, or thromboembolic events. So restricting blood in stable patients saves resources without compromising any single clinical metric. Now, your liberal transfusion strategy, it was associated with higher risk of transfusion adverse reactions, excluding volume overload. Now, this slide outlines the specific trial-validated numbers that you can take directly to your wards or clinical practice. So for critically ill patients in the general ICU, the TRIC trial established a safe trigger of less than 7 grams per deciliter. For patients in septic shock, the TRIS trial confirmed that less than 7 grams per deciliter remains non-inferior. In acute upper GI bleeding, Villanueva and Odutayos data prove that keeping the trigger below 7 actually reduces portal pressures and lowers rebleeding risk. Now, moving to the surgical suites, cardiac surgery targets less than 7.5 grams per deciliter based on the TRICS-3 and the Titer 2 trials, while major orthopedic surgery targets less than 8 grams per deciliter based on the FOCUS trial, even in elderly patients with cardiovascular risk factors. So this is our defensive line. However, I must also emphasize that blood stewardship is not blind adherence to a single number. There are also evidence-based exceptions where a threshold of 7 to 8 grams per deciliter can actually be actively harmful. Now, these major exceptions include severely symptomatic patients, patients experiencing an acute myocardial infarction, patients with acute traumatic brain injuries or subarachnoid hemorrhages, massive transfusion protocol scenarios, and individuals with complex hemoglobinopathies or chronic highly adapted anemias. So let's break down the data for these key exceptions. The first exception is the symptomatic patient, where our trigger shifts into a broader gray zone of 7 to 10 grams per deciliter. So what qualifies as a true transfusion triggering symptom? So we are looking for clear physiological evidence of end organ oxygen deprivation, like symptoms of active myocardial ischemia, profound orthostatic hypotension, or severe tachycardia that is completely unresponsive to volume resuscitation and marked dyspnea at rest. So I want to highlight a major clinical caveat. Mild exertional fatigue or standard chronic anemia symptoms are not sufficient indications for acute transfusion. So we can also look into surrogate measures such as new ischemic ECG changes to justify triggering a unit transfusion above a baseline of 7 grams per deciliter. Now let's talk about the heart, specifically acute coronary syndrome, where our clinical target hovers between 8 to 10 grams per deciliter. So for hemodynamically unstable ACS patients, transfusion is clearly indicated if they have ongoing active hemorrhage, signs of worsening ischemia, or overt shock attributable to their anemia. We must manage these inputs carefully to minimize malperfusion while mitigating the risk of volume overload. Now, for stable ACS patients, we individualize care. If they have severe risk factors for reinfarction or highly complex coronary anatomy, we maintain a more liberal transfusion threshold of less than 10 grams per deciliter. Now, if they are completely stable with no high-risk reinfarction features, we can safely drop our threshold to less than 8 grams per deciliter. Now, the nuance in managing ACS comes from a fascinating divergence in recent clinical trial data. On one side, we have the massive MINT trial published in the NEJM, which randomized over 3,500 acute MI patients to a hemoglobin trigger of 7 to 8 versus 10 grams per deciliter. The primary composite outcome of MI and death at 30 days did not show a clinically statistical difference. However, the trial noted a distinct, clinically alarming trend towards higher mortality and recurrent MI rates in the restrictive arm. Conversely, the smaller reality trial showed a trend towards lower 30-day risk for major adverse cardiac events in its restrictive group. Because of this conflicting data, and the MINT trial's warning signs regarding cardiac mortality, standard practice remains appropriately cautious in active, fresh myocardial infarctions, leaning toward a liberal 8 to 10 grams per deciliter buffer. Now, it is critical to separate our fresh acute MI patients from patients with stable chronic pre-existing coronary artery disease. So for chronic CAD, an 8 gram per deciliter threshold is highly supported. Now look at the FOCUS trial, which enrolled over 2,000 elderly patients with known cardiovascular disease undergoing surgery. So they found identical rates of 60-day mortality or inability to walk independently between restrictive and liberal groups. So similarly, in the classic TRIC trial, stable coronary artery disease subgroup analysis showed equal 30-day mortality with significantly lower mortality seen in restrictive strategies for less acutely ill and younger cohorts. Chronic stable vascular disease does not require a liberal strategy. Our next major exception represents one of the most exciting recent paradigm shifts in neurocritical care, the acute brain injury patient. So published in JAMA, the landmark TRAIN trial evaluated adult ICU patients with traumatic brain injury, subarachnoid hemorrhage, or spontaneous intracerebral hemorrhage. So the brain, unlike the gut, is uniquely intolerant of anemic hypoxia. The TRAIN trial demonstrated that a liberal strategy maintaining a hemoglobin of 9 grams per deciliter yielded a statistically significant 10% absolute risk reduction in poor long-term neurological outcomes. So, furthermore, patients in the liberal arm, they experienced significantly fewer serious adverse events related to secondary cerebral ischemia, 8.8% versus 13.5%. So crucially, this liberal target did not cause any increase in deep vein thrombosis, ARDS, or multi-organ failure. So in acute brain injury, a more liberal transfusion strategy saves brain tissue. Now, there are still areas in our practice where large-scale randomized trial data remains limited. So this includes ambulatory outpatients, CKD patients, and oncology patients undergoing active treatment or receiving palliative care. So in these scenarios, clinical guidelines suggest using the location of care or the closest underlying disease state where data is available to guide your actions. However, the general consensus rule remains highly resilient. In the absence of active, severe hemorrhage, or severe acute cardiorespiratory symptoms, a baseline hemoglobin threshold of 7 to 8 grams per deciliter is still entirely appropriate for these patient populations. So to synthesize our red blood cell discussion, let's track this excellent clinical assessment algorithm. So when managing an anemic patient, of course, we do clinical and laboratory assessment, and then we ask, what is the hemoglobin level and is it rapidly dropping? If it's under 7 grams per deciliter, blood transfusion is appropriate with rare exceptions. If it falls in the 7 to 10 grams per deciliter window, you must immediately screen for ACS. So if ACS is present, a target under 10 is appropriate. If it's absent, look for hemodynamic instability or direct cardiac symptoms. So if those are present and they are caused by the anemia, we transfuse. So if the patient is stable and asymptomatic, stop and let yourself be guided by the trial targets we discussed. So 7 grams per deciliter for general ICU and GI bleeds and 8 grams per deciliter for stable CAD and non-cardiac surgeries. Now, if it's more than 10 grams per deciliter and the patient's hemoglobin is not rapidly dropping, blood transfusion is unlikely to be needed unless there are any extenuating circumstances. Now, let us shift our focus to the second objective of our forum, the platelets. So, this is an incredibly timely update as the AABB and the ICTMG have just released their comprehensive international guidelines. So, these guidelines mark a definitive evidence-based shift towards restrictive platelet transfusion strategies. And this extensive literature review confirms that utilizing lower, more conservative platelet triggers does not increase patient mortality or cause severe bleeding across multiple hospital settings. And by adopting these targets, we can significantly mitigate patient costs, avoid transfusion reactions, and protect our critical blood center inventory shortages. So this infographic lays out the core architecture of the 2025 guidelines. So under strong recommendations, we have our classic medical prophylaxis trigger for stable, non-bleeding chemotherapy or stem cell transplant patients, which remains firm at less than 10 times 10 to the 3 per microliter. However, a major change is the trigger for a lumbar puncture, which has been safely lowered to less than 20 based on extensive cohort safety data. The guidelines also issue a strong recommendation against prophylactic transfusions for stable consumptive states like dengue fever. Now, for conditional recommendations, a central line in a compressible site can safely be placed at a trigger of less than 10, while major non-urachal surgery maintains a trigger of less than 50. And finally, they recommend against routine platelet transfusions in non-bleeding cardiovascular surgeries or non-operative intracranial hemorrhage where the count is over 100, even if the patient is on antiplatelet therapy. Now, our final clinical pillar brings us to obstetrics and the critical role of fibrinogen in postpartum hemorrhage. So, pregnancy is actually a naturally hypercoagulable state where baseline maternal fibrinogen elevates to 4 to 6 grams per liter as a protective mechanism. Because of this high baseline, a drop to 2 grams per liter represents a profound factor consumption and serves as our strongest clinical predictor for progression to catastrophic massive hemorrhage. Therefore, our transfusion trigger is clear. So we initiate immediate replacement therapy the moment your plasma fibrinogen drops below 2 grams per liter in the presence of active obstetric bleeding. So you can achieve this goal-directed correction using either 10 units of cryoprecipitate as an initial pull or 2 to 4 grams of fibrinogen concentrate, which offers rapid, volume-restricted, and tract-free replacement. So as we close this session, so let us take a look at our master matrix of key takeaways. So for red blood cells, remember that restrictive targets of 7 to 8 grams per deciliter is safe for your general stable patients. Your exceptions are acute coronary syndrome, where you maintain a buffer of 8 to 10 grams per deciliter based on the MINT trial, and acute neurocritical injuries, where the train trial demands a liberal target of greater than 9 grams per deciliter. For platelets, follow the 2025 guidelines. Maintain greater than 10 for medical prophylaxis, greater than 20 for lumbar punctures, and greater than 50 for major surgeries. For obstetric hemorrhage, watch that fibrinogen level closely. Target goal-directed replacement with cryoprecipitate or fibrinogen concentrates the moment it dips below 2 grams per liter during active bleeding. So ultimately, blood stewardship maintains practicing precise, evidence-based medicine. It means having the clinical confidence to provide exactly enough blood products to maximize our patients' functional outcomes, while actively protecting them from the hidden toxicities of unnecessary exposure. Let us make our collective practice to transfuse the patient's actual clinical status and comorbidities, and not simply a laboratory number. So thank you very much for your time and attention, and I'll be happy to take questions or comments later. Thank you very much.